Right, good morning, conference. Good morning, ladies and gentlemen. Welcome to this plenary on the future of health and social care. We have two excellent speakers who will outline their agenda for the next 5 years and the role of local government in achieving our shared priorities, improving the care and the health outcomes of our communities. So before I hand over to Jeremy, I just want to say a few words about the central role of adult social care for councils in ensuring the future sustainability of the NHS. You will all understand the pressing need for the spending review to address the continuing funding gap for adult social care, which is increasing by at least 700 million a year, and for government to fully fund and implementation of the Care Act reforms introduced this year. Without this, and despite the major improvements in efficiency that councils have managed to achieve, councils will be faced with very difficult decisions about funding to other council services, libraries, planning and children's services. In order to continue providing services for some of our most vulnerable people, we understand that the government has to make some very difficult decisions as well, but our strong advice is that funding mainstream adult social care properly for the millions who rely on it must be at the very top of the priority list, even, I would suggest, if that means postponing other important reforms, such as Phase 2 of the Care Act. So we look forward to working with the government and NHS England to shape a new health and care service that reduces pressures on hospitals, uses resources more efficiently, but most importantly, achieves a lasting improvement in the health of our nation. So our first speaker, who needs absolutely no introduction, as Secretary of State for Health, Jeremy Hunt led two major reform agendas for the last government, the Health and Social Care Act 2012 and the Care Act 2014. This is his first opportunity to outline to you, the political and professional leaders of local government, his priorities for health and social care in this Parliament. We will be joined by Simon Stevens later on, and I'm afraid we're going to be doing a bit of rotating doors in Jeremy Hunt having to leave a little bit earlier than the end of this session, and Simon Stevens coming in a little later than the beginning. So without further ado, can I ask the Secretary of State and for the auditorium to give a very warm welcome to him to the podium. Thank you.
Good morning, conference. Let me start with a thank you. Right now, the health and social care sectors face a triple whammy: an ageing population, a budget squeeze, and rising consumer expectations. And all of you are operating at the coalface of those pressures. So I want to thank you for the superhuman efforts that you're making to make sure we don't let down our most vulnerable citizens. I see those efforts in my own county, Surrey, where Surrey County Council are facing up to extraordinary challenges with great courage, but I know this is true across the country, and I am incredibly grateful. Elections focus on the differences between parties, but 2 months on from this last one, we should reflect that there was actually consensus on a critical aspect of health and social care policy. All parties were committed to going further and faster on integration. It also appeared prominently in the Queen's speech, and as we have been talking about it, you have been getting on and delivering it through the Better Care Fund, where remarkable progress has been made. This includes 84,000 fewer hospital bed days, around 13,000 more older people remaining at home after discharge, and 3,000 more people being supported to live independently according to current plans. It includes every part of the country now on track to start sharing records with the NHS, the most vital bit of integration plumbing. And 72 areas, around half the total, are actually putting additional money of their own into the pooling arrangements because they're so enthused about its potential to improve care. And they're right to be enthused because some of the plans we're seeing are truly transformational. 75% of the pool budgets are being ploughed not into NHS acute care, but into social and community care, exactly the shift we need to keep people healthy and happy in their own communities, to prevent rather than cure, and to avoid unnecessary hospital admissions. One piece of the jigsaw, though, is missing as we embark on this journey, and that is effective metrics. Integrating health and social care is a first, perhaps a global first, so it'd be fatal if the dead hand of Whitehall tried to tell you how to do it. But we do need to know how well it's going, area by area, so we can identify best practice, learn from each other, and provide support where things are going wrong. And to help that, I'm developing a set of unified metrics, bringing together the work on the Better Care Fund with the broader objective of health and social care integration. These will use a methodology agreed by the Department of Health, CLG, the NHS, and local government through the LGA. They'll be independently verified, published quarterly, with the first set coming out in December. And this way we will help ensure that the process of integration carries on at the pace we need over the coming years. Now, integrated care is safe to talk about because we all agree on it. Trickier is the other issue on your mind right now, which is the spending review. I know you know that I'm not in a position to gainsay the Chancellor on this, but I can set out some of the principles that will guide our approach. The first is that proper funding for all public services in the end depends on a strong economy. So we do need to stick to our challenging deficit reduction plans as outlined before the election, which we recognise will be particularly challenging for local government. Indeed, even with a protected budget, it will be challenging for the NHS too. On a do-nothing scenario, demand for our services will rise by £30 billion by 2020, with only £8 billion of additional funding. So we're having to find £22 billion of savings, the most difficult efficiency ask of the NHS in its history. I'm, of course, only too well aware of the financial challenge that local government has faced over the last 5 years, and we all know there is still more to do. But, and this is our second principle, we will fail in our responsibilities to the most vulnerable if we approach those efficiency challenges separately, allowing the pressure of budgets to entrench a silo mentality between the NHS and local government. What happens in social care is inextricably linked to what happens in the NHS. A strong NHS needs a strong social care system, and a strong social care system needs a strong NHS. It would be easy, but quite wrong, to balance the books by reducing access to care or the quality of care delivered. But if local authorities do that, NHS A&E departments will be overwhelmed. And if the NHS does that, the demand for permanent residential care that you have to pay for will mushroom. So we must follow the harder path, finding smart efficiencies that improve patient care, something we can only do by joining forces and facing those efficiency challenges together. But there's a third partner we need in this endeavour, and that is the people who actually use our health and social care system. When Beveridge first called for a national health service, he attacked the 5 great evils of want, disease, ignorance, squalor, and idleness. His guiding principle was that the security of a national health service should be dependent on cooperation between the state and the individual. In other words, the state should offer security in return for service and contribution. Sometimes the state has not delivered as well as it should, whether shipmen, Bristol Heart, Mid-Staffs or Winterbourne View. So my biggest priority as Health Secretary has been a move towards intelligent transparency so that we find out quickly where any problems might be happening. As a result, for the first time, we now know how good our local hospital is. We have independent ratings for GP surgeries and care homes. We publish consultant surgery outcomes and are looking to do the same for medical specialties. From next March, CCGs too will be held accountable for the overall quality of healthcare delivered in their area. The NHS is moving from a closed organisation to an open one with real accountability to taxpayers and patients for the quality of service delivered. But to deliver the highest standards of health and care, the people who use those services need to play their part too. Personal responsibility needs to sit squarely alongside system accountability. And that is the national conversation I want to start today. We need to start by taking more personal responsibility for our own health. The independent American-based Commonwealth Fund recently ranked the UK the first of all major health systems in the developed world. On access to health services, the UK is unparalleled. On the safety of care, we're amongst the best. Yet on one key measure, we fell far behind. When it comes to preventing illness or leading healthy lives, we are bottom of the pack, ranked 10th out of 11 leading countries. That is deeply undesirable in a taxpayer-funded system that relies on a sustainable level of demand for services. This country pioneered through local government, clean drinking water and clean air in cities. We effectively invented what is now called public health. But looking at some of the indicators, you wouldn't know it. Despite falling smoking rates, nearly 8 million people in England still smoke, and treating smoking-related illness costs the NHS an estimated £2.7 billion a year. Half the difference in life expectancy between our richer and poorer areas is caused by smoking-related illness, with 2/3 of smokers starting as children. We also have higher obesity rates than nearly anywhere else in Europe. This is closely linked to soaring type 2 diabetes rates, up 61% in a decade, now affecting 1 in 16 of the adult population and costing the NHS £8 billion a year. Whilst childhood obesity has plateaued, are we really content with 1 in 5 children leaving primary school clinically obese, with 3/4 of their parents not even aware that they have a problem? Thankfully, people are starting to take more responsibility. Doctors report dramatic increases in the number of expert patients who Google their conditions. And this can be challenging for doctors not used to being second-guessed, but it is to be warmly welcomed. The best person to manage a long-term condition is the person who has that long-term condition. The best person to prevent a long-term condition developing is not the doctor, it's you. Which is why last year, following changes to the GP contract, the number of GPs offering their patients online access to a summary of their medical record has risen from 3% to 97%. And this needs to be the start of a much bigger change where everyone feels firmly in the driving seat for their own health outcomes, and an area where the NHS and local government can work closely together. Now, part of this change in mentality needs to be more personal responsibility for the use of precious public resources. On the back of Lord Carter's report on inefficiencies in procurement and rostering in the NHS, we've recently begun a big piece of work to bear down on waste in hospitals. We're insisting on a laser-like focus from the hospital sector to make sure that every penny counts. But there is a role for patients too. There's no such thing as a free health service. Everything we are proud of in the NHS is funded by taxpayers, and every penny we waste costs patients more through higher taxes or reduced services. Yet estimates suggest that missed GP appointments cost the NHS £162 million each year, and missed hospital appointments as much as £750 million a year. That's nearly £1 billion that could be used for more treatments or the latest drugs, on top of which we spend £300 million a year on wasted medicines. People who use our services need to know that in the end they pay the price for this waste. So today I can announce plans to publish the indicative medicine costs on the packs of all medicines costing more than £20, which will also be marked as funded by the UK taxpayer. This will not just reduce waste by reminding people of the cost of medicine, but also improve patient care by boosting adherence to drug regimes. And I'll start the processes to make this happen this year with an aim to implement it next year. The third, and perhaps the most challenging area where we need to take more personal responsibility, is around care for the elderly. You don't need me to describe the burning platform. By the end of this Parliament, we will have 1 million more over 70s, 1/3 of them living alone. Yes, the health and social care system must do a better job at looking after them, but so too must all of us as citizens as well. Shockingly, in Edinburgh last week, police had to break down the door of a top-floor flat because it had been so long since the door had been opened. They had to pick their way through mounds of unopened mail to reach the body of a man who may have been left undiscovered in his flat for up to 3 years. Statistics from the LGA indicate that in 2011 in England there were 2,900 council-funded funerals. That's around 8 lonely funerals every single day, half of which were for over 65s. Now, are we really saying that these people had no living relatives or friends? Or is it something sadder, namely that the busy, atomized lives we increasingly lead mean that too often we have become so distant from blood relatives that we don't even know when they're dying? In Japan, nearly 30,000 people die alone every year. And they've actually coined a word for it, kodokushi, which means lonely death. How many lonely deaths do we have in Britain? Where, according to Age UK, 1 million older people haven't spoken to anyone in the last month. It isn't all bad news. We have 6 million carers in the UK who do a magnificent job, even if they don't always get the thanks or support they deserve. We have some of the most active charities and social support systems of anywhere in the world. But the uncomfortable truth is that praising the heroic army of carers and volunteers, as all politicians do, is not enough. If we are to rise to the challenges we face, taking care of older relatives and friends will need to become part of everyone's life. Other countries are starting to wake up to this challenge. A Chinese proverb states that an elderly person at home is like a living golden treasure. At the moment, around 40% of Chinese older people live with their children, but in Beijing they have a policy to increase that to 90% by 2020. China even passed a new elderly rights law against neglecting or snubbing elderly people, which mandated that people should visit their elderly parents often, no matter how far away they live, with fines or prison sentences as penalties. Now, Western traditions would rightly resist state interference on this scale. But France too passed an elderly care law in 2004, requiring its citizens to keep in touch with their elderly parents. They did this, perhaps topical to mention today, after a heat wave left 15,000 people, elderly people, dead, many of whom were left for weeks before they were found. In Italy, they have a well-established system of badanti, or au pairs, or as I like to call it, nannies for grannies. They provide the majority of elderly care in Italy and take care of older relatives while busy parents go out to work. In the Netherlands, they have introduced a different type of au pair system for elderly people, where students are offered rent-free accommodation in nursing homes in return for spending at least 30 hours a month with some of the elderly residents. Another model is championed by the remarkable organisation LGA, which has adopted a revolutionary approach to the care of people with learning disabilities. As a young man in the aftermath of World War II, Vanier Lage visited a grim institution in Paris for people with learning disabilities. He was accosted by a young resident who asked him simply, "Will you be my friend?" He was so struck by this cry of loneliness that he invited two men from the institution to live with him in his home. And this became an international movement where people offer a year of their time to live alongside their charges. As Vanier said, when you share the same bathroom and your toothbrush shares the same mug, it's different. And there are now 147 thriving L'Arche communities in 35 countries, including our own. And we have some amazing homegrown schemes too, such as the Home Share scheme in Dorset to Forth Valley, Scotland, and the Shared Lives programme in 150 locations from Bradford to Brighton. Or the extraordinary efforts of individual citizens like Maria Boot Hanford, a speech therapist from Greenwich, who was so moved by the plight of her elderly neighbours that she negotiated with her NHS employer to work 4 days a week so she could use Fridays to spend quality time with 3 different elderly neighbours and visit local nursing home residents. But these individual examples of inspiration shouldn't mask our national shame. 1 in 10 older people have contact with their family less than once a month. And 4 million people say TV is their main source of company. Despite many local examples of innate British kindness and decency, the national picture is far from kind and far from decent. We should also note the hard-headed economic arguments that impact on this debate. All families have different needs and situations, and for some residential care will be right, but carry on as we are and we will need 38,000 more care home beds, 38,000 more care home beds in the next 5 years. That is the equivalent of building 100 more care homes every month for the next 5 years. The impact of this on you, the local authorities who fund 40% of all residential care beds, would be disastrous. Care home residents are also some of the most frequent users of NHS services, so the financial impact on the NHS would be equally severe. Recent evidence suggests that change is starting to happen, and the latest ONS figures showed a welcome increase in multi-generational households. But with only 16% of older people living with their children in this country, compared to 39% in Italy, 40% in China, 65% in Japan, we are starting from a low base and need to ask whether the pace of change is sufficient. We're proud of the new rights for carers enshrined in last year's Care Act and made a manifesto commitment to increase support for full-time unpaid carers. Passing new laws requiring people to care for relatives is not the British way, but I do want to make sure that we are learning from the best of what happens around the world. So I can also announce that my new Minister for Community and Social Care, Alistair Burt, will develop a new carers strategy that looks at the best of international practice and examines what more we can do to support existing carers and the new carers that we'll need. The new strategy will ensure we deliver that, but it will do more. By looking at best practice from around the country and the world, we will seek to answer the big question: what do we need to do as a society to support people who are caring now, and crucially, to support the millions who will have a caring role in the future? We can't put our heads in the sand on this critical issue. Now, I've said before that I want Britain to be the best country in the world to grow old in. But the government, nationally or locally, can't do this alone. attitudes need to change too, so that it becomes as normal to talk about elderly care with your boss as about childcare. Family planning must be as much about care for older generations as planning for younger ones. A wholesale repairing of the social contract so that children see their parents giving wonderful care to grandparents and recognise that in time that will be their responsibility too. Responsibility for our health, responsibility for our families, responsible use of public resources, a revolution in personal responsibility to match the revolution in health and care provision that we're all determined to offer. Thank you very much.
Thank you very much, Jeremy. That was a wonderful start to our session, and I know you're with us for a short while, but you might be able to take a few questions. So can I just encourage people to be brief in their questions, not to make speeches, but actually to get straight to the point so that we can get the most that we can in, and so I'll open it up to the auditorium now. I've got, I've got 1, 2 here, and can I see another? And 3 here. So we'll start with these 3. So 1 in the front here, 1, 2 rows behind. Thank you, and one just on the edge there. Thank you, Mike.
Secretary of State, councils have been incredibly innovative over the past 5 years and implemented radical change to deliver better services at a lower cost. Bearing in mind we've seen a 40% reduction in our income. And that's been a real focus on early intervention and prevention, particularly on the health and care side. Now, we believe we can actually add significant improvements to the healthcare services that we see in our community if we bring them together more quickly but under council control. Can you please give us support to do that?
Well, I think we need to bring health and care services together, and I think we have shown with what's happening in Greater Manchester with Devo Manc that we are very open to the potential of putting those together under council control. We've set out in the NHS, what we don't, I think, want is a big structural reorganisation, because I think we've been through lots and lots of those in the history of the NHS, and so what we want is local initiative. We've set out with NHS England 3 models, but essentially all of them move to the concept of a lead provider for health and social care in every area, and people taking, a team of people in each area taking overall responsibility for the health and care provision in that area. Local authorities are one potential route. You can have fantastically good GP consortia that are going from strength to strength, as happens with Vitality in Birmingham. You can have extremely good care that is led by the acute hospital, where it's a well-run hospital, as happens here in Harrogate. And we are neutral between those different models, but we want local authority to play their part in whichever of those models that we adopt. That's the reason why I place a lot of importance on getting the metrics right, because I think we can afford to be neutral about who is in the driving seat in each area if we have a proper independently assessed metric about the quality of health and care in each area, so that we are seeing what works and also able to step in if there are problems.
Thank you very much. I'll take those next 2 together. So one over in, yep, right, and then the other one. So can I ask you to give your name and where you're from?
Morning, Secretary of State. Colette Wyatt-Lowe, Chairman of Hertfordshire Health and Wellbeing Board. What do you think the NHS can learn from local government efficiencies?
And the one on the end there. Quickly back with the mic. Thank you.
Thanks, Jim Harker, leader of North Hampshire County Council. And I like really much the idea of a revolution in personal responsibility, particularly through the generations. One thing that strikes me is that government departments perhaps should work more closely with the Treasury on these sort of things. Because if I want to build an extension or alter my house for me to live in as a granny flat later on, I pay £100,000 to do that. I then pay £20,000 in VAT to the government. And that seems wrong to me. And if you could somehow give that a traction, take the VAT, make it zero rated for those sort of granny flat extensions and alterations, that would add an incentive to do what you want to do.
Thank you. 2 questions.
Yes, I mean, I think the point is well made. We obviously have an overriding priority to deal with the deficit, so it's challenging to do anything that actually costs the Exchequer money. But the point I think you're making, which is what I was trying to say in my speech, is that we have a big national debate about incentives for childcare and make it easier for childcare. And we need to recognise that in terms of our national finances, it will be as critical to make sure that we make it easy for people who want to take good care of their elderly relatives. And there are lots of different things that one could consider, but I think it's a very important point. Colette's question, what can the NHS learn from local government? Well, I think the NHS has not had to make cash reductions in the money coming through the door in its history. And we're going to have more money, but it's not going to be anything like enough to deal with the extra demand. So the impact is actually that the NHS needs to make cash releasing efficiencies across the board if we're going to be sustainable over the next 5 years. And local government have been thinking about how to do that for a very long time. And I think, the efficiencies that local government have made, the fact that over the last 5 years, satisfaction with local government services actually went up, despite the very challenging cuts that you had, means that you are a shining example of the truth that you can deliver better services at lower cost. And this is the message that I say to the NHS at every speech I have with NHS leaders. It's not a choice between quality and money. Actually, they go together. Higher quality and lower cost are completely compatible, and the best and safest hospitals have the lowest costs. And so that is a big message for me to the NHS.
Jeremy, thank you very much. I know you've got a tight timetable, and I know too that we have our other speaker in the wings. So I'd like very much to thank you on behalf of the whole conference for coming today and explaining your vision for the future. Thank you very much. Thank you. Yeah, I think I can do that. Okay, right. We've got Simon Stevens. One more. Good to see you. And I think the Secretary of State is just going to listen to a little bit of your starting point, and we look forward to that. So it is like revolving doors. So thank you very much for joining us today. It's been a great pleasure to have you here. And I have to say, without further ado, can I please ask you to go straight forward, Simon Stevens, and give us your vision. Thank you.
Good morning. It's a pleasure to be here in Harrogate. I'm actually spending this afternoon talking to the Royal College of Psychiatrists Annual Congress in Birmingham, so I will compare and contrast the two groups come this evening. I was reflecting, coming up here this morning, that the world has moved on a long way since I had the chance to stand before you in Bournemouth a year ago, when at that point there was obviously a big debate about what would be the direction of local authority leadership around devolution and around health and social care. And I do think that concretely we can say that together we've made some pretty important strides over the course of the last year. Obviously, the Better Care Fund is now up and running, and not just with the funds that the health service has put into the pot. I think the most encouraging feature of that is the £1.5 billion over and above that local authorities and the local NHS have themselves decided to add into the kitty. I talked a year ago about the importance of not just thinking about health and social care integration as a kind of wholesale structural thing, but also that the NHS should learn the lessons from the experience that social care has had with personal budgets, 650,000 people with social care personal budgets, and that we would work with local authority partners to create the first ever pooled health and social care personal budgets. And very pleasingly, we've done that with the LGA, with ADAS, with the consortium of voluntary organisations, and now in 9 areas across the country, most of the southwest, Bromley, Cheshire, Lincolnshire, Luton, Tower Hamlets, Portsmouth, Hampshire, Stockton-on-Tees, getting going on that 2 months into that programme, potentially to be quite transformative. And of course, the context for all this, as far as the NHS is concerned, is that since we met in Bournemouth, we have set out our stall before the nation for the next 5 years through this thing called the NHS 5-year forward view. And part of the big argument we made in that forward view was that there are some hardwired fragmentations in the way in which care works in this country that have their roots back in the post-war, immediate post-war period, and it's time to change those. And we talked about 3 big integrations that we need. One between physical and mental health services, one between primary and specialist health services, and the integration between health and social care. So I thought just very briefly this morning I might touch on 3 opportunities, 3 areas for fruitful collaboration that I see between the NHS and local authorities over the course of the next year and beyond. Obviously, this is not a comprehensive rendition, but 3 big areas that I think we have got to make substantial progress on. The first of which, obviously, will be the next steps we want to take on health social care. And picking up the question that just went to Jeremy there, say a little more about the role of Devo-Manc type arrangements, but other models as well. Secondly, I want to talk a bit about the prevention agenda, given the vital responsibilities that you as local authority leaders and officers now have for public health. And then thirdly, talk about the broader economic impact that the health service and local government together can have in our communities across the country. So quite an expansive set of topics, but I think it's at times like these that we need to think big and go faster rather than think narrow and huddle behind our respective portcullises. So health and social care integration. The fact is that this is both about improving people's experience and it's about making the money work. And we know that times are tight, times are going to be obviously incredibly difficult for local authority finances over the next 5 years. The LGA has made that argument forcefully. I have certainly, in fact, on my very first day in this job last April, made the point that nobody should kid themselves that just combining 2 leaky buckets produces a watertight funding solution for care in this country. But the reality is that we've got together to make the best of the opportunity we have in front of us. And in the 5-year forward view, we made an argument that said, as we do that, we do not want a new structural reorganisation because that ends up diverting energy rather than unleashing it. And we do not believe that the way in which health and social care works together can or should look the same in every part of the country. We are too big a country with too diverse a set of populations and starting points and strategic opportunity in front of us to assume that simply fiddling with a set of administrative arrangements or mucking around with a headed notepaper from Whitehall will actually produce the kinds of locally responsive services that the people we're here to serve require. So no structural reorganisation and not one size fits all. So what that means, I think, and actually echoing a comment I just heard Jeremy make in response to a question, is that for us to make progress, we have got to think about 3 or 4 different approaches that will be available in different parts of the country. One, of course, will be the voluntary expansion of the budget pooling between health and social care on the BCF type model. Another will be the blending of health and social care budgets for particular client groups linked to personal choice, the integrated personal commissioning program that I spoke about, beginning with high need groups where there's a very strong overlap between health and social care, people with learning disabilities, severe and enduring mental health problems, children with complex needs that span health, social care, education, and people with physical disabilities, people with complex needs at risk of care home admission. That's kind of a no-brainer. That's what we're now doing in these 9 local authority areas. But over and above the budget pooling and the integrated personal commissioning, we're also testing new models that frankly have been off the table in the National Health Service since the year dot, and right here in Harrogate, in fact. The hospital, the North Yorkshire Council, the Harrogate Council, the local GP group, the commissioning group, are coming together to form an integrated care organisation to which we will likely delegate the full population budget. It's called a primary and acute care system. Of course, we have to have special health service jargon for these kind of things to ensure that no normal human being can actually track what we're up to. And as you know, that's just one of a small number of the lexicon of acronyms that are at our disposal for this purpose. But there's a simple idea here, which is that in Harrogate, right here, you can wander over to the hospital and they will tell you what it is they need to do to work more closely with their social care, with their primary care services, the community, the mental health, and we are giving them the permission to get on with it. And we're doing that in 29 parts of the country, covering 5 billion people, and this is just the start. So that's a kind of different way into this conversation. It's not just about blurring budget lines, it's about integrating that with changes in the way care is delivered itself. And then, of course, I'm very personally supportive and obviously have helped lead the Devo Manc proposition, which together with the authorities, the 10 authorities in Greater Manchester, the 12 CCGs, the 15 NHS providers covering 2.8 million people, NHS England has signed a memorandum of understanding with a view towards the full pooling of £5 billion worth of NHS spending and £1 billion worth of social care spending beginning next April. And Howard Bernstein and I chair the partnership board that is ensuring that that has a smooth takeoff under local democratic control and with the full engagement of the National Health Service for Greater Manchester. So I think this is going to be a very important test of the proposition that you can put 1 and 1 together and get more than 2. Or in this case, 5 billion and 1 billion, and get more than £6 billion worth of value. And that is because the proposition that we're working on there is that it's not just about health and social care. It's also about a lot of broader economic benefits that will, as a result of the degrees of freedom that that combination will bring about, potentially be derivable. So the sorts of tests that we in the NHS England would be applying to other areas interested in that kind of proposition would be, does it fit with the options that make sense in that particular geography? Is there leadership, energy and capability with a track record of success and strong mutual relationships locally? Are the plans tailored for local circumstances? Is there clarity of vision and a game plan about what will be achieved? And, as I say, does that include using the power of the combined health and social care pound to produce benefits that go beyond just those 2 statutory services? But of course, we've actually got a lot more work to do across the health service than just on the question of how to fuse budgets and care delivery. We need mutual aid between the National Health Service and social care services over the next several years. In care homes, we know that if the health service did a better job of supporting people living in care homes, then that would have a substantial impact on the number of people admitted to hospital as emergencies. So in 5 parts of the country now, we're testing a much improved NHS offer, and in places like Gateshead, that has shown 14.5% reduction in the number of emergency admissions from care homes into hospital services. Equally, the health service needs to do a better job of providing rehab support to people being discharged from hospital so they do not end up admitted to a care home rather than back to their own home where that would otherwise have been an option. We've got a huge workforce set of issues that we've got to sort out between ourselves, including on nursing and the constraints that that has imposed in the way of costs and staffing issues in the care sector. We've got some radical views on how the nursing skill progression and careers might develop so that people entering the care assistant roles have got good future training and possibilities to look forward to. And then we've got some particular things we've got to get right on learning disability services, where I'm sorry to have to say that in the top half of the country, your chance of being stuck in a long stay institution, if you have learning disabilities, is in many cases double that than if you happen to be living in the bottom half of the country. So the NHS has got to finish the job of the closure programme for some of these long stay units, and we will be setting out our plans together with local authority partners on that later on this year, in the autumn in fact. So there is obviously a huge health and social care agenda in the time available. I can only skirt over the surface, but give you a sense of what some of the active ingredients there are going to be. But the second big theme that I wanted just to take the chance to compare notes on is the contribution that you and we can make to the health of the people in our communities across the country. And obviously the unring-fencing of the public health funds with all of the opportunities and the pressures that that creates, the further transfer of north of £800 million worth of health visiting and other services in just a few months' time in October, it is critically important for us both that we get that right and that we are able to, on the back of it, prove the sceptics wrong and demonstrate that the magnifying power of local authority leadership in this area actually produces greater benefits than would be obtained had those services remained captive within the National Health Service orbit. And there are a whole range of things that can be done there, as you know. Many leading local authorities are making huge progress on the big health risks for our population. I'm very worried about childhood obesity, as are many of my colleagues. You all know that, as I frequently bang on about, not least because I'm the father of 2 primary school age kids, 1 in 10 primary school age kids when they start primary school obese, 1 in 5 by the time they get to year 6, just off to secondary school. We can't blame our children for that. That is us as parents, that is schools, that is the food industry, that is the obesogenic environment, it's the regulatory system, it's the price signals, it's affordability and access and acceptability. It's a whole set of things that we've got to work on together. Otherwise, we've just got this huge wave of avoidable type 2 diabetes and cardiovascular disease and blindness and amputations, and now we know 1 in 5 cancers caused by obesity as well. So no one institution, organisation, sector can solve this, but together this is the new national health challenge of our time. I coined the phrase obesity is the new smoking, which is not to diminish the fact that smoking is still our biggest killer, but we've got to get serious about this obesity agenda, and there are a huge range of important things that you, and only you, can do. You have planning powers that can be used to help ensure that the high street is a healthy high street, and authorities like St Helens and Waltham Forest and Barking and Dagenham have pointed the way there. We know that there are issues around the location of fast food joints near schools. Studies in Brighton and Hove suggested that 400 metres is actually not enough of a travel time for kids either in their lunch break or after school. 800 metres plus, as part of the big national conversation we're going to be having about devolution and more powers for elected local authorities and mayors, this has to be in the mix. We've got health checks, and we have not properly got the connectivity between the results that health checks are producing and the actions that individuals and the health service itself needs to take. We are just kicking off a diabetes prevention programme nationally that needs to connect properly with the work the local authorities are doing on health checks. So this is an all to play for agenda, but it's actually mission critical, not just for the health of the nation, it's mission critical for the financial sustainability of the National Health Service itself. We said in the forward view that with 28 to 30 billion pounds of demand pressures over the next 5 years, and with some of that funded by central government. The rest is going to have to be taken care of through a combination of sweating the money we already spend, redesigning care, including at the health and social care interface, and getting serious about prevention. That is our shared endeavour. If we don't get that right, the National Health Service will end up dealing with more emergency hospital admissions, crowding out increasing elements of public spending that would otherwise have been available for other needed services. So this is in our shared interests as well as our shared mission. So yes, health and social care, yes, prevention and public health. But the third and final point I just briefly want to make is that the NHS has probably not been a terribly good partner in many ways on the broader economic regeneration, the housing agenda, work, economic participation that many local authorities are now actively getting their teeth into. And so, recognising, as your new LGA chair has rightly pointed out, the need to kickstart the construction process across the country to get the number of housing units we're going to need, the Health Service wants to play its part with you on that. We've got 15 hospital trusts, mental health trusts alone, with about 5,000 units worth of surplus land. There's a lot more there. As hopefully home construction ramps up, we want to work with you to build in the health promoting environments into those kinds of developments. And so today I'm extending an offer on behalf of the Health Service to those parts of the country that want us to roll our sleeves up and come engage with you and your developer partners, housing associations and others around how do we make the new model health services and design in health and independence into those kinds of environments. For schools, for example, where new housing is planned, then obviously the local authority rightly thinks about those other services. The health service is often quite slow about thinking about what do the GP services or the community nursing services or other things need to be, and some of those will not be delivered in the conventional model. Some of those will need to respond to the new ways that people want to interact with the health service. They'll have to be digital, they'll have to be virtual, they will have to be alternative ways of blending education assets, health assets, police, the infrastructure of these local communities. We don't have a fixed view on precisely what that model will look like in different parts of the country, but for any of you interested in our national as well as local engagement with you, where you've got developments pending, then please let us know that by the end of September. We're putting out a short 2 or 3 pager today, and you will have our full attention. So, in summary, this is obviously a big moment for the National Health Service. We took the view that it was important going into the general election campaign that we just had, that the Health Service confidently set out our stall before the country. We are very pleased with the public backing that we have got for that, including from the government, but also, frankly, recognising that there is very substantial cross-party agreement on the big things that need to change in the National Health Service. And although that was not the flavour of most of the debate during the election campaign, the fact is that when you peel back those layers, you see that this triple integration agenda, primary and hospital services, physical and mental health, health and social care, and the broader contribution the NHS can make to a national life, that is an agenda that sits true with the British people and explains why the NHS continues, with your support locally, the contribution of our 1.4 million people, to be one of the most treasured institutions in our national life. Thanks very much.
Thank you very much, Simon. That was great. And we have got just a very few minutes, if that's okay, to take a quick round of questions. I'm going to kick it off with Chairman's privilege, if you don't mind, and ask the first one, because we're aware that at the NHS England board meeting in March this year, you said that when the much heralded £8 billion that's the NHS funding gap figure that people have inferred from the forward view is talked about, one of the important provisos for that was that there was not a further substantial offset in the availability of social care across the country. And to the extent that is the case, that will of course produce more demand on the NHS. So really, can you comment further on the way the NHS relies on adequately funded social care system? And then I'm going to take 3 questions from the auditorium, and I've got some hands up already, so can I have a set of 3? I've got 1, 2 here, and 1 just here. So, okay, where are the microphones? Brilliant. 1 just on the, right, 1 there, 1 immediately behind you, and there's 1 further along. Right, first question.
Robin Brown, I'm Chairman of the Health and Wellbeing Board in Northamptonshire. Be very interested in taking up your opportunity of consolidating both health and local authority land and premises within the county. We have various different organisations that are involved, and we have, of course, an enterprise partnership which should be able to lead that. And therefore, I would hope that our leader, who's sat just beside me, will make sure that we write to you very soon proposing some straightforward plans. So I hope that we can be seen to be first on that list.
Right. Thank you, Robin. And I think there's 1 immediately here. Thank you.
Councillor Steve Ealing, Deputy Leader, Sandwell Metropolitan Borough Council. I was actually going to ask the Secretary of State a similar question to this, but didn't get in there. But you both rightly mentioned the role of public health in prevention going forward, and clearly there have been many references to the extra £8 billion for the NHS. But of course, public health has been suggested for cuts in the budget on the 8th of July for in-year cuts this year, and presumably for further cuts when the spending review is announced in the autumn. How do the cuts to public health factor into the greater plans about how public health is going to act as a real prevention mechanism within your overall plans for the health service?
Thank you very much. And there's just 1, there's a lady just on the centre there. I'm sorry, they're all from there. It's quite hard to see. Thank you.
Hello, I'm Fiona Marshall, Chief Executive of Malden District Council. You made the point about the NHS is slow to catch up sometimes on the delivery of facilities in localities. Local authorities are planning and now delivering growth in their areas, and we certainly in our area have major concerns from the community about the lack of facilities to meet that growth, so GP facilities, for example. We've met with NHS England and had those discussions, and very often the answer is there is no more money. How do we square that with our community when we have to answer their concerns?
Okay, thank you very much. That's 3 very diverse questions, and my own as well.
Yeah. Robin, on your question on shared infrastructure, great. The truth is we've got work to do still in the National Health Service on this, because our property assets are distributed in many pockets, individual provider organisations, something called NHS Property Services, which can be quite remote from some of the local decision processes, is my observation. But the fact is that, somewhere between probably realistically $1.5 billion at the low end and up to $7.5 billion at the very high end of unused or partially used real estate and property is sitting across the National Health Service. In London, you could fill Hyde Park with surplus NHS property. We don't anymore have the luxury of not getting serious about this. Now, some of that, obviously, we need to kind of create economic value off the back of in order to help with our funding challenges. It cannot all just be kind of free gratis for other things. So trying to get that balance right is obviously something that's going to have to be a local conversation. But we clock the fact that we need to marshal our forces as well. On the question on Sandwell and the public health budget cut, that would have been a good question for Jeremy, I agree. I think what I would say is, look, I think we kind of, appreciate the fact that there are very substantial funding pressures right across the country. Look, we're running, a budget deficit of about 5% of GDP still. So, of course, those pressures are going to be there. I would hope that we don't see further erosions in support for public health, because that would be penny wise, pound foolish. Equally, obviously what we've got to do is we've got to make sure that we are getting really good impacts for the money that we're spending. But a lot of these services are the sorts of things that if you kind of chip away at them, you don't immediately notice, but quite quickly you get the boomerang effect. So, if we do things on drug and alcohol services, quite quickly that has an impact. If we do things on sexual health services, quite quickly that has an impact. So that's why, as stewards of those programs now, I hope you will, and Sandwell has a proud tradition in this regard, and John Middleton, former public health director, in fact I saw John a couple of weeks ago, we were talking about precisely this, so I get the point completely. Then Fiona, on the point about how quickly can we get in place new GP services where there's past population growth, the issue has been that the NHS funding formula has lagged the creation of these. So basically, you need people to kind of turn up, start living, get counted in the census, and then they kind of plug into the funding formula, and then kind of several years later, that sort of feeds through into the local resourcing. So what I'm offering today, no, we can't do it kind of in one fell swoop everywhere, but certainly in, call it 5 or more parts of the country that are high growth, we would like to kind of have that kind of conversation prospectively about how we get the kind of upfront new design, so we don't just keep on doing the same old. Otherwise, what happens is you get the population growth, and there are many parts of the country that are going to have high housing growth, and that's a good thing. And then we sort of just try and plug in the old way of doing the National Health Service after the event instead of having the upfront conversation. That's what we want to try and do.
Thanks. And can I just draw you back to mine?
To your question, Izzy, yes. Well, I think in a sense I think it should hopefully be obvious that it was not an accident that in the last public board meeting before the election, we invited Carolyn Downs from the LGA and David Pearson from ADAS to set out the stall publicly on the contribution that social care makes, not just to the millions of people served by it, but also the interdependence of the National Health Service. One issue where I don't think are sometimes our own worst enemies is I don't actually think we have very good ways of measuring the mutual impact. And so, without getting kind of incredibly into the weeds on this, there are some quite good empirical studies showing the impact of reducing spending in care homes on subsequent inflows to the hospital system. What there aren't are good studies at the moment showing the impact of the availability of domiciliary care or indeed informal care. Given we've got 1.4 million full-time unpaid carers in this country, what happens there has a huge impact as well. It's kind of one unpaid carer for every nurse and doctor and physiotherapist in the National Health Service. So we're actually trying now, with support from the LGA and ADAS, to find some geographies where we can collect the data sets right across the care ecosystem to answer that question, so that we can actually make that argument in a tangible way, not just one that we intuitively know to be the case.
Well, thank you very much, and I'm very grateful to the conference to staying on, because we have rather overspilled.
I would just say one last thing. Somebody asked the question of Jeremy that I just heard about how the lessons that the NHS should take from local government. I think one lesson is that local government has changed profoundly, and the anecdote. Is anybody here from Lambeth Council, by the way? Do we have a Lambeth delegation? Yes. So I happened to attend the Lambeth mayor making a few weeks ago when, as a former Lambeth councillor myself, the guy who was elected alongside me on the same day in the ward in Brixton that I represented, Donatis Anyanwu, became mayor of Lambeth. And it struck me that the progress in boroughs like that is evidenced by the fact that 17 years ago at the mayor making, they were singing the workers' flag is deepest red, and this year it was Jerusalem.
Fantastic.
Thank you.
Can I just ask everyone to thank Simon for his wonderful presentation today, and we're very grateful for you coming. Thank you.